Okay. Great. So nice to meet everybody here. My name is Sirish Vullaganti. Let me share my slides. Give me 1 second. So I actually don't have permission to screen share right now. Okay, right. Yes, and I can actually hear you now too. Great. All right, so again, my name is Sirish Vullaganti. I'm the director of heart failure at Lenox Hill Hospital, and today I'm going to talk about heart failure, which is a term that I'm sure many of you are familiar with, and it's something that you've heard a lot. Maybe you yourself have heart failure. Maybe you know somebody with heart failure. It's a very broad term. There's a lot of myths and misconceptions, and so what I want to do today is to just explain what heart failure is, and how we treat it. And so the way I'm going to kind of organize this talk today is one, just defining what is heart failure. It's a term that gets thrown around a lot. And so I really want to spend some time focusing on what is heart failure, what it means to have the diagnosis of heart failure. Next, I'll talk about what are the causes of heart failure, which is important to know. Also, how we diagnose it as cardiologists. And then also, if you don't have heart failure, what are steps you could prevent to utilize to prevent getting heart failure in the future? And then finally, which is a big part of what my job is how do we treat heart failure? And so I want to start with a very big huge warning sign here is that I hate the term heart failure. I'm a heart failure cardiologist. And I can't tell you how much I want to change the term heart failure, and a lot of my colleagues feel the same way. And the answer and the reason for that is that a lot of people hear the term heart failure and they think failed heart. If you fail an exam, you can't turn that into an A. But that's not true when it comes to heart failure. What heart failure is just means that at that moment, the heart isn't pumping enough blood to the rest of the body, or it's not doing it in a normal fashion. And it doesn't have to be permanent. So I like to call it heart weakness. The heart can get better. We can improve the way the heart functions, and we can improve the way you feel. But unfortunately, we're still stuck with the term heart failure right now. But whenever I get patients and they say, "Oh, I'm here to see a heart failure cardiologist," I have to spend a little bit of time to dispel that notion that their hearts are failed. And so I want to make it very clear that it's not necessarily a failed heart. And heart failure encompasses a very wide spectrum. It can be just somebody who gets a little bit short of breath after walking or running 3 miles, or it can be someone who's completely asymptomatic. And then it can go all the way to the very end of someone on life support with multiple machines, hooked up to multiple machines and temporary pumps and multiple medicines. And so there's a huge spectrum here. And most patients fall into this category in the beginning of a little bit more mild to moderate heart failure. And it's very common. We think about 5 to 6 million US adults live with heart failure. Once you get to the age of 80, about 2/3 of people have heart failure. So it's very, very common. And again, with a huge spectrum as well. And so before we talk about, what is heart failure, I think it's important to understand the normal function of a heart itself. And I'm sure a lot of you know this, but I just want to spend a little bit of time. So there's 2 sides of the heart. There's the right side and the left side. We think of the left side as the main pumping chamber. And what the heart really is at the end of the day, quite simple. It's a muscle, it's a pump, and it sends oxygen to the rest of the body in the form of blood. And so all of our muscles, our tissues, our organs, they need oxygen to work, and they get oxygen from blood that's pumped from the heart. And so we start with the left side. The heart squeezes, pumps blood. All of our tissues, all of our organs takes the oxygen that it needs to do its daily functioning. And then once that blood is taken out, that oxygen poor blood comes back into the right side of the heart. Now that blood needs to get oxygen to support the rest of the body, so it gets pumped to the lungs, where that blood again gets filled with oxygen, goes back to the left, and the cycle continues and continues, 60 to 100 times a minute. And so really, again, the heart is just simply a muscle that pumps blood to the rest of the body. And if you have heart failure, I'm sure your cardiologist has mentioned something called an ejection fraction, or EF. And it's one of the best, it's not a perfect method, but it's one of the best ways we have of estimating the function of a heart and simplifying it into a number. And so the way I like to think about it is, so a heart, again, pumps blood, but it doesn't pump out all of the blood that it starts out with. Usually a heart pumps out about 50 to 55% of the blood that it starts with, and there's still a little bit left. And that ratio, how much it pumps out, that's called the ejection fraction. And so if a heart pumps out half of the blood that it started out with, that's 50%. If it pumps out all of it, it's 100%. But a normal ejection fraction is around 60% or so. And so if you think about a balloon that's full of air, if you completely deflate it, that's a very, very high ejection fraction. But if the balloon starts out very big and ends up just a little bit smaller, that's a very low ejection fraction. And so that's one of the best ways we have of estimating the function of the heart. And there's really two types of heart failure, and that depends on if the ejection fraction is normal or not. Again, normal being about 55% is what we consider normal. And so half of the patients have, half of heart failure patients across the world have low ejection fraction heart failure, where their ejection fraction is low, it's not pumping out as much. And the other half have the other kind, where the ejection fraction is typically normal. So it's a 50-50 split. The low ejection fraction heart failure, I think, is a little bit easier to understand. You have a weak heart muscle that's not able to pump blood well to the rest of the body. And so you get some of the symptoms of heart failure, and I'll talk about that a little bit later. The other form of heart failure, which again is just as common, the heart is actually pumping out blood normally. It's pumping out 50, 60%, sometimes more, but people still have symptoms of heart failure because for lots of different reasons, but in general, it's the heart stiff. The heart stiff, it can't relax. And when the heart can't relax, the blood has to go backwards, which ends up being in the lungs, causing shortness of breath, and in the legs, oftentimes causing swelling. But those are the two types of heart failure, and the way we treat it is typically very different. And so your doctor will probably tell you which of these you have, or I know I at least talk to patients about which one of these they have. And so what are the symptoms of heart failure? These are some of the warning signs. If you start to have some of these symptoms, it'd be a good idea to tell your doctor about this so they can get some of the testing that we'll talk about to know if you have heart failure. One of the most common symptoms is shortness of breath. Oftentimes that's because fluid gets into the lungs. When fluid goes backwards from your heart, it gets into the lungs, and that causes breathing problems. Usually that's worse when you're laying down flat because it's just the way gravity works. You lay down flat, that's when the fluids tends to accumulate in the lungs, or when you're exerting yourself. Those are common symptoms of heart failure. Again, swelling in the legs or abdomen. If the fluid's not pumping out from the blood, it just kind of sits in the tissues in your body, and then it leaks out into the rest of your body. And so you get swelling in your legs. If you kind of press down your legs, you might get an indentation, sometimes swelling in the belly too. Also getting tired or fatigued when you're exerting yourself more than usual. That's another symptom of heart failure. Those are the more common symptoms. Other symptoms, dizziness, lightheadedness, poor appetite, weight loss, feeling of your heart racing. Those lots of different things can cause that, but sometimes very advanced heart failure can cause those symptoms too. And so what causes heart failure? What are the different things that cause heart failure? And so we'll kind of break it down into some of the more common causes. So one is coronary artery disease. And I know there was a previous talk about this before. I won't go into it in too much detail, but essentially if there's a major blockage in one of your heart arteries, or if you've had a heart attack before, that'll cause the heart muscle to get weak. When the heart's a muscle and when it's deprived of oxygen, it kind of turns into scar tissue and it gets weaker and it just can't pump blood as well. And so having a heart attack or Having severe blockages of your heart can certainly cause your heart to get weak and cause heart failure. High blood pressure is one of the most, so heart disease, the first one I mentioned, that's the most common cause of heart failure in the country. Hypertension is probably the second most common cause of heart failure in our country as well. Very, very common, as you know, high blood pressure. And if it's poorly controlled for a long period of time, the heart just kind of starts to lose its ability to keep up. And so it's hard. The heart has to pump against a very high blood pressure. And initially it's fine, but at some point it can only do so much, and it just starts to give out. It starts to get bigger, starts to get weaker, and over time will lead to heart failure as well. Genetics is another, what we're finding out is a rising cause in heart failure as well. So certain mutations can affect the muscle of the heart, cause it to not form correctly, cause it to form lots of scar tissue or get weaker. And so there's lots of mutations that can certainly cause heart failure, or mutations that can predispose somebody to get heart failure as well. And there's a number of those that we can test for. Alcohol in high quantities is also a potential cause of heart failure. Not a glass of wine a day, 1 or 2 glasses of wine, but excessive alcohol abuse, binge drinking. Alcohol is a direct toxin to the heart, and long-term excessive alcohol use can certainly cause heart failure, and cutting back can also improve heart failure. Certain chemotherapy agents that are sort of a little bit older, we're still using today, are known to cause heart failure as well. We didn't know this as much back then. Nowadays, we understand this risk a lot more. And so for people who are getting certain chemotherapy agents, oftentimes, if they're known to cause heart failure, they get some testing beforehand to make sure that's the case. But certain drugs, including chemotherapy agents. Viruses, you've probably heard about myocarditis that was occurring around the time of the initial COVID-19 pandemic. And so various different viruses, COVID or not, can certainly cause the heart muscle very quickly to get very weak in a very short period of time. The viruses invade the muscle of the heart, just like they do the rest of the body, and lead to heart failure that's usually very sudden and drastic. Another thing is, I won't go into too much detail, but certain what we call infiltrative processes, so rheumatologic conditions, inflammatory conditions, other things that can, autoimmune conditions can kind of fight the heart muscle, treat it like somebody that's not itself, and cause it to get weak over time. And lastly, and I know this may not be satisfying, but probably the most common cause of heart failure is what we call idiopathic, meaning we don't know. We don't know exactly the cause. We can do certain testing, but it's just a cavalcade of things that all work together to cause heart failure. But that's okay, because the treatment is the same regardless of what the cause is. And so how is heart failure diagnosed? Well, a number of ways. So the tried and true and probably easiest way is through the physical exam. And that's why it's really important that we get good, thorough physical exams, both to diagnose heart failure and to evaluate how the heart failure is going. And so we will check the vein in the neck. Oftentimes, there's a vein that empties into the heart. And if we start to see that's kind of going higher and higher, that's a sign that there's extra fluid. Certain murmurs, certain extra heartbeats are signs of heart failure. We can sometimes hear fluid in the lungs with our stethoscope. We can feel swelling in the abdomen and the legs. Those are all signs of congestion and heart failure, and that would lead to further testing. The other thing is an echocardiogram. And so this is the kind of the baseline first step in assessing if somebody has heart failure or not. We're able to view with ultrasound images how the heart's functioning. And we get lots and lots of information. It's actually incredible how much information we get from the echocardiogram. But we certainly get the ejection fraction that I talked about before, but we also get more information. How are the valves of your heart doing? How thick is the heart? How is your heart relaxed? We get lots of really useful information for the echo, and it's a standard part of workup for heart failure. While this won't diagnose heart failure, we'll oftentimes get electrocardiograms. That's very quick and easy to do. Almost every cardiology office can do this in a couple of minutes. Just looks at the electrical activity of the heart. Again, it doesn't diagnose heart failure, but it can look for some abnormal heart rhythms that sometimes go along with a diagnosis of heart failure. Certain blood tests can be very helpful for us as well. And specifically, there's a blood test called a BNP. It stands for B-type natriuretic peptide. It's a protein that the heart releases when it's not happy and stretched out. Elevations in that blood test are typically signs that somebody has some degree of heart failure, either mild or severe. And so that's a helpful test if we're not sure about the diagnosis. And I use it a lot too to see how somebody's doing. So somebody who has heart failure, if they're getting better, we usually see that number get better. If they're getting worse, sometimes we see that number get worse. So it's a very useful blood test. And there's lots of other tests that we can do if we're not sure about the diagnosis, or we want to get a better sense of the severity of the diagnosis, or we want to know what's causing the heart failure. So heart catheterizations can look for blockages that I talked about before, can measure exactly how much the heart's squeezing, how much fluid it's holding on to. CAT scans and MRIs can help us take a better look at the muscle of the heart itself and what might be going on. Certain exercise tests can also help as well to see how you're doing. So there's lots of different testing that we can do, but really the fundamental baseline is the physical exam and the ultrasound of the heart as well. And so I think it's really important to talk about how to prevent heart failure. All the patients I see typically already have the diagnosis of heart failure, but what can we do to prevent heart failure, which I think is very important. And the way I like to think about that is we go back to our initial causes of heart failure, right? Because if we know what causes heart failure, then we can just program backwards and figure out, okay, what can we do to help prevent that? And so starting with the first main cause, which is coronary artery disease, so there's lots of different resources for how to reduce the risk of having a heart attack or heart blockages, and a lot of it's genetic, but there's a lot of things that you can do yourself. And so one is eating a healthy diet, and there's lots of different diets that are advocated for, but in general, cutting out bad fats, cutting out trans fats, cutting out saturated fats, healthy oils, fruits, vegetables, whole grains, if you do eat meat, lean meats. And so there's lots of different resources, and Dr. Giannis is absolutely the expert, so I'm going to stop talking about this, but there's lots of different ways that you can adjust your diet to reduce the risk of developing heart disease and blockages down the line. Maintaining an active lifestyle is really important, both for treatment of heart failure and preventing it as well. Having more muscle mass can help your baseline heart function as well. And so maintaining an active lifestyle is very important. Tobacco is a huge risk factor for developing blockages in your heart, which can then cause heart failure. So smoking absolutely has to be off the table. I know Dr. Dunbar talked about cholesterol as well. And so making sure that you're keeping up with your cholesterol, you're getting it tested, and based on your risk factors, are keeping your cholesterol where it needs to be. And lots of different doctors and cardiologists can help make sure that you're at your targets. Being overweight or obese can certainly increase your risk of heart failure, and poorly controlled diabetes can also lead to heart disease and heart failure and heart blockages as well. And so making sure that that's well controlled. As far as controlling hypertensive heart disease that can cause heart failure. So one is just making sure your blood pressure is under control. And so some of that might be dietary, some of it might be exercise, and oftentimes many people need medications. But based on your risk factors, your doctors will have a specific blood pressure goal for your blood pressure target. But certainly we want to avoid hypertension, especially if there's risk factors for heart failure. As far as genetics, a lot of that is just letting your doctor know if you have a history of heart failure or heart disease. And so I think it's always good to ask your family, all your first-degree family members, if there's anything that runs in your family, cardiac or not, because we're learning more and more a huge link between genetics and heart disease. And so understanding your genetic risk profile can also help us making sure that if you have a family history of early heart failure, we'll probably do genetic testing and look for specific mutations that cause that. And then alcohol, it's as I mentioned before, just avoiding excessive alcohol. If you are drinking, just to keep it to a minimum. And there's no consensus of what that is, but I always just say certainly avoid binge drinking, especially if you have other risk factors for heart failure. And so what most of what I do now is really focused on the treatment of heart failure. So if you already have the diagnosis, how do we treat heart failure? And some of it's medications, but also some of it is not medications as well. Lifestyle changes and changing habits. And also what I often tell patients is, I want you to be empowered. I want you to kind of take over your own health, because we work together. And I do part of it, but certainly as a patient, they're a big part of it as well. And so one of the things I always tell patients with heart failure, especially those who tend to retain extra water, and maybe even need to be hospitalized to get fluid taken off, is to weigh yourself every day. So I always say every day, wake up, get on the scale and record your weight, and record your blood pressure, and do it at the same time every day. And oftentimes people who get into the hospital with extra fluid, oftentimes before that, there is a sign that their weights are going up. And oftentimes, so lots of things can cause weight to go up, but certainly one of them is fluid. And so that can sort of precede the development of breathing problems and swelling in the legs. And so we always keep a close eye on the weights. And oftentimes for heart failure patients who have issues retaining fluid, we'll have goal weights. And so we'll say, okay, this is your goal weight. Try to stay within this range. If you're getting out of this range, give us a call and we can troubleshoot. Is this water weight? Is this something else? But monitoring your blood pressure, your weight, and also how you're doing, your symptoms, that can really help us adjust the doses of your medications and try to reduce the risk of needing to go to the hospital to get some of the fluid taken out. Not all patients, but some patients with heart failure do have issues retaining fluid. And so for those, we'll talk about restriction of fluid, keeping fluid intake down. Typically, we say 2 liters or less. For some people who are very quick to retain extra water and extra fluid, we might make that even less. I have some heart failure patients who, with all the medicines, they tend to be dehydrated. So I actually tell them, please drink more, drink 6 liters of water a day. And so it's very dependent on the people, but oftentimes for people who do retain fluid, we do counsel about limiting how much fluid and how much water you're taking in. Sodium restriction is also important for heart failure as well. It's important for blood pressure and also important for heart failure. And so the reason for that is what salt does is when we eat salt, when our body absorbs salt, it also absorbs water too. And so whenever you take in salt, you're taking in an equal amount of extra water, and that tends to cause fluid retention as well. And so typically for most heart failure patients, we do recommend keeping the sodium down to 2 grams per day. And I'll be honest with you, it can certainly be very difficult. If you're looking at nutrition labels, it can be very hard to keep that sodium intake low. And so a couple of some do's and don'ts here. So one, it's trying to avoid adding extra salt to your meals when you're cooking. There's lots of herbs and spices that don't have salt. And so Mrs. Dash is an example, lemon pepper. We don't want you to eat cardboard, but there's other ways to get the food to taste a little bit better without having salt that's going to cause fluid retention. And there's lots of healthy foods that don't have a lot of salt. Processed meats and deli meats have so much salt there, especially canned food, soups. All of those are foods that can really spike your sodium levels. And so those are just a couple, and I have some other things here that just kind of help with keeping that sodium restriction down. And again, it's all dependent on the patient. So some people don't retain extra water, have lower blood pressures, might be a bit older, and so I actually might not tell them to restrict their sodium, and other people might not tell you to cut down on salt. But for many heart failure patients, we do oftentimes counsel on the reduction of salt intake. Exercise is really important. So cardiac rehabilitation is one of the approved treatments for heart failure, and there's different ways that it's done. Most commonly, it's at a gym or a center like a gym. There's a cardiologist there, there's a nurse practitioner there, there's an exercise physiologist, and oftentimes a nutritionist. And we all work together to help every patient have their own supervised exercise plan. And it really does a number of things. One, it helps boost confidence. Having a diagnosis of heart failure, sometimes you can feel like, oh, I can't walk more than 5 blocks. I can't possibly go on a treadmill for 3 miles an hour. But when you have healthcare providers there, when you're hooked up to electrodes, so we're watching your heart rate, you're being watched closely. It's almost like riding a bike with training wheels. There's people there, we can support you, and so if anything bad happens, that's the right place for it to happen. And almost rarely do bad things happen there. And so it's a closely monitored setting. We can really help patients push themselves without that fear of what happens. And a lot of it is getting to the point of not feeling restricted by heart failure. Heart failure is not a fatal diagnosis necessarily. We don't want people to feel like they have this thing that's holding them back. My goal is for all of my patients to have as normal of a life as possible. And part of that is understanding your limitations and to try to get up and move as much as possible. So cardiac rehabilitation is great for this. And even if you're not doing it in a supervised rehab program, just some form of exercise. It could be as simple as not taking the elevator and taking the stairs more often, keeping track of your steps and try to keep it above a certain level, just walking more, or even standing. There's lots of ways to increase your physical activity, and that really helps condition the heart as well. But really probably the best evidence for how we treat heart failure effectively is actually with the medications. And so when somebody has heart failure, and mostly I'll talk at this point about the reduced ejection fraction heart failure, weak heart muscle, the body releases all of these hormones that thinks it's good for the heart, but they're actually bad for the heart. And so we have a number of medications that target different pathways, different hormone pathways. And all of these medicines have been shown, most of the medicines here that I've showed have been shown to improve the ejection fraction, improve symptoms, keep people out of the hospital, and make people live longer. And so I always tell patients there's 4 different classes of medications at this point, and I want you to be on all of these and at the highest doses possible. These are heart strengthening medications. So the first one is a category, the first 3 medications right here. I have some names here, but ones that you probably will see if you have a history of heart failure: Entresto, lisinopril, losartan, valsartan, anything ending in an RIL or a TAN or Entresto. This is all kind of the same category of hormones that block this bad hormone called angiotensin. And what angiotensin does is it causes the blood vessels to constrict, it causes you to hold on to water, and it causes the heart to get weaker. And so all of these block that hormone and make the heart better. Probably the best of these is Entresto, which is one of our newer medicines. And it's really a fantastic drug. On average, in the big study, the ejection fraction improved by 9%, which is great. But at the end of the day, you're people. You don't feel your ejection fraction all the time. What you're doing is living life. And so Entresto actually also makes people feel better as well. And so compared to another drug that already had a benefit in heart failure, people on Entresto, as I'm showing here, they felt better just doing gardening or housework, showering, doing recreational activities or hobbies, having to jog or catch a bus, being intimate with their partners, and just living a life. They tended to feel better. And when you do the math, the difference of how better people feel with Entresto is the equivalent of being 9 years younger. And so if you're 70 with heart failure, on average, people on Entresto felt like they were 61 based on how much better they felt. And so not only do we use these medicines for your benefit to get your heart better and to live longer, but we're doing this to make you feel better too. It works both ways. Other medicines too. So beta blockers are another group of medicines. So metoprolol, carvedilol, that's the most common ones they're used. They lower your heart rate and they decrease that sympathetic tone that can make the heart worse. There's another medication called spironolactone or eplerenone that also blocks a hormone called aldosterone. That helps the heart get better as well. And the last one is a new group of medications called SGLT2 inhibitors. You've probably seen commercials. Farxiga, Jardiance are the two big ones. They used to be used to treat diabetes, and they still are. But now we know that even without diabetes, they also strengthen the heart and keep people out of the hospital, live longer, and feel better. And so we have these 4 classes of medicines here that I call them heart strengthening medications. And my goal is to get everybody on all of these and at the highest dose as possible to have the greatest risk, the greatest chance of improving heart function. And it's very common to get full improvement and sometimes even complete resolution of heart function with medicines. Some people also need diuretics to keep the extra fluid off. So Lasix, torsemide, the pills to make you urinate more to help keep that extra fluid off. And a number of other medicines as well. So we have a whole list of medicines here, and there is a method to a madness. There is a reason why we prescribe these medicines, and they work and can help you feel better too. If you have a very low ejection fraction, if you're one of these people whose ejection fraction doesn't improve with the medicines, but certainly does happen, then you might be at increased risk of a potentially fatal heart rhythm. And so just like how if you go to the airport or a store, you'll see defibrillator pads there. Well, you may not always be in a place that has those. And so there's implantable defibrillators. And what those do, it's a same-day procedure. A rhythm doctor will go in, put a wire in the heart and a little canister right above it. It goes under your skin. And what it does is it listens to your heart. And hopefully it never goes off. That'd be great. But sometimes if the heart does go into that rhythm, it's there to deliver a shock right away and get your heart back into a regular rhythm. And this is shown to be a life-saving device for people who need it. And so what I tell patients is, think of it like airbags in your car. The airbags don't make your car better, but you don't want to drive a car without airbags. Hopefully you won't ever get into a car accident and need to use those airbags. But if you do, you sure hope those airbags are there. And so that's what a defibrillator is. Again, some people need this to prevent the risk of sudden death. We have other newer devices and treatments as well. I'm really blessed and excited to be in the field of heart failure at this time where we just have an explosion of new therapies. One of the things that we do, and it's a procedure that I do, is something called a CardioMEMS, where we can implant also a same-day procedure, minimally invasive. We put a little sensor in the artery of your lungs, and that sensor can detect if you're starting to build up fluid or not. And so every day you lay on a special little pillow at home, you press a button and upload it to the cloud. We see these numbers that kind of show how you're doing from a heart failure perspective. And that can trigger a phone call to say, hey, take an extra dose of Lasix. You're starting to fill up with fluid, or actually you're getting dehydrated, cut back on your diuretics. And so this is a really helpful tool for some heart failure patients where we're having a hard time keeping them in the right place. We have here at Lenox, we've done a number of other kind of more advanced treatments as well. Getting the heart stronger by changing the way the heart sees calcium in the muscle, decreasing that sympathetic fight or flight response with a sensor that uses the receptors in your carotid artery. So we have a couple of other devices that can help improve symptoms as well. And I don't want to talk about this in too much detail, but also, part of my job in heart failure is deciding who needs, who actually truly has end-stage heart failure. And some patients do. Again, it's the minority, but some patients do. And if that's the case and you're a candidate, we have, again, life-saving therapies, heart transplants for which numbers are going up year after year. And something called an LVAD, which is a surgical heart pump that takes over the role of the heart. So for people who do have end-stage heart failure, it's not end-stage in the sense that we do have options. But again, this is the minority, and my goal and priority is to get people not to need these devices. But if possible, then we can certainly do that. And that's actually it. So again, these were the 5 questions that I had mentioned before. So what is heart failure? Again, the heart's just not efficient at pumping blood to the rest of the body. Lots of different causes of heart failure, mostly blockages in the heart, high blood pressure, genetics, certain drugs and medicines. We diagnose heart failure typically with an ultrasound, but we also use the physical exam and other testing. There's lots of lifestyle modifications to help prevent heart failure, and we have a number of treatments. And the mainstay, the 1, 2, and 3 priorities for treatment of heart failure are medicines that are life-saving and heart strengthening.
Excellent. Thank you, Sirish. Can you actually hear me?
Now I can hear you, yes.
Well, you probably are not seeing me, is that right? Or are you able to see me?
I can see you too.
Okay, perfect. Wonderful. I had to switch over to my phone. So
Okay.
glad that you gave such a nice overview of heart failure as a topic. It is a confusing topic, even for physicians. I think there's a lot of things that are misleading, and sometimes people get focused on, that number of the ejection fraction, and if it's low, then I can't possibly have a decent quality of life, or if my pumping function is normal, then I should feel fine, and there's no way I should be symptomatic. But it's such a complicated disease state, and you really broke it down really, really nicely. So that was excellent. One question I have for you is, what do you suggest patients work on with their doctors? Are there specific things they should be asking for? Are there specific things they should be tracking? Are there specific tests that they should be getting on a regular basis?
Yes, so certainly that it's a lot. So if you do have a diagnosis of heart failure, I think sometimes there is a little bit of a complacency bias, where sometimes we can feel very content with how things are going. And sometimes we lose the opportunity to optimize certain medical therapy, which we know is life-saving. And so even if you're doing okay, I think it's always good to ask your doctor, am I on the best regimen possible? Because we don't always settle for B+. It's something we want to strive to be as good as possible. And so making sure that your doctor has you on the best regimen possible. And then the other thing is just really, focusing on your symptoms. And for people who have had heart failure for a long time, sometimes they get used to being short of breath. Sometimes they get used to not being able to tie their shoes, and that's just a way of life. And I try to urge people to, and caution patients that it doesn't have to be the normal. It doesn't have to be the normal. We have so many options now. And so I think another thing too is, and sometimes your family can be really helpful there, because they know what you were like a year ago, 5 years ago, or even a month ago. And so I think for doctors, for us not to be complacent, and for patients too, not to be complacent, and always make sure that we're doing the best we can to help you feel better.
That's great advice. And you're right. I find that the fluid overload kind of sneaks up on patients, sort of like little by little, like your legs are a little bit bigger. And then maybe you're just a little winded when you're walking around, but you figure, I'm just a little deconditioned. It's nothing. But you're right. You have to be your own detective. You have to kind of track all these symptoms and really reach out early when you start to notice these differences, because there's ways to actually get you back on track. Really, really important advice. So I definitely get lots of points for bringing up the vegetables, of course. I really, really appreciated that. So yeah, diet, I was so fascinated by the impact of lifestyle on heart failure, and how much, both in terms of causing heart failure and most of the things that you talked about, high blood pressure, diabetes, alcohol, various things that cause heart failure are very much tied into lifestyle. So, one, the fact that you could actually prevent most cases of heart failure from an optimal lifestyle. And then two, that you can actually improve your case of heart failure by improving your lifestyle. So for patients, for example, who want to start exercising, what do you suggest? How do they get started? If they have heart failure, is there anything they need to do in order to start an exercise program?
Yeah, so I always say, so every patient's different. And so a lot of it is discussing with your doctor or cardiologist first, if you have maybe a more severe form of heart failure, or maybe you have a type of heart failure that predisposes you to have abnormal heart rhythms, that might change the amount of exercise. And so I think the first thing is just to make sure the doctor who knows your care is counseling appropriately. And then, I always say, you know yourself better than I know you. and to not push yourself more than what you're capable of doing, and to start slow. You don't have to get to that running a marathon in a week. And so it really just starts slow. It's as simple as getting out, walking, standing more, and then start to do a little bit of more, getting to the gym, getting your heart rate a little bit higher. And yeah, it's more of a gradual process, and also knowing when to stop and not pushing yourself too much. And so for people where it's difficult of knowing where to stop, I think cardiac rehab is really helpful, because you have a little bit of reassurance of no, you can go farther.
Yes, exactly. We're very big fans of cardiac rehab for various conditions, whether it's for coronary artery disease or it's for heart failure or valve disease, et cetera. But there's known benefits from going to a cardiac rehab program, and we're building virtual cardiac rehab as well at Northwell. And there are a lot of programs out there, so important to get connected. But great advice to start by getting your doctor's input and start slow. No question about it. Now, you talked about therapies, and really the past few years for the heart failure world have been incredible with the releases of new medications. And I always talk about how the biggest problem we have as physicians is really choosing which of the many good therapies we should go to next, because there's so many out there. So for you, in thinking about the patients that you're taking care of, are there specific things that guide you towards, different medicines, whether the patient has kidney disease or diabetes, or if they have coronary artery disease or anything else that helps you to choose which medicines to go with?
Yeah, it's a great question, and you're absolutely right. As we have more and more developments and more progress, it gets more and more confusing, because where do you start? It used to just be two medicines, one medicine, and now we have it's an alphabet soup of different medicines that we can use, and so it certainly gets very tricky. Certainly, I always tell patients I understand it's very difficult to take such a huge regimen of medicines, and I am a huge fan of reducing polypharmacy in general, and it's unfortunate that I ended up in the field of heart failure, where polypharmacy is the name of the game. That's how we get people better. And so I think a lot of it is just counseling patients of why we're using these medicines, and I hope I did that today, because there's a reason for it. And in terms of which one to start, because oftentimes heart failure patients are taking at least 4 medicines just for their heart failure, but many of them also have, as you mentioned, diabetes, so they're on medicines for that, heart disease, they're on medicines for that, high blood pressure. And so it oftentimes ends up being a lot. And so in determining which medicines to start at which particular time, there's no right or wrong answer. Some of the medicines have multiple beneficial effects. And so the SGLT2 inhibitors that I mentioned, Farxiga, Jardiance, those are beneficial in patients with heart failure. They're also beneficial in patients with diabetes. They're also beneficial in patients with chronic kidney disease and also coronary disease. And so it's sort of a kind of gets multiple things at once. So I'm very quick to start that medicine on patients who have those coexisting conditions, because it's sometimes killing 2, 3, sometimes 4 birds with one stone. If the blood pressure is very high, I tend to use Entresto at higher doses early on, because it's a very effective blood pressure lowering medicine, sometimes too much. And so if blood pressure is very high, I'll reach for that very early on. And yeah, we oftentimes will do these titration visits. And so in the first few months, we do frequent visits every 2, 3, 4 weeks sometimes, to get the medicines up, follow the blood work, making sure that we're on a stable regimen.
Got it. Excellent. So yeah, definitely so much great medicine out there, and we can definitely use those different disease states. One other thing I just want to clarify for everyone out there is how this works with respect to so many fields in cardiology. We do have so many little niches of expertise, and we really work together. And sometimes, as a cardiologist, I'm a general cardiologist, a preventive cardiologist, women's heart, et cetera. I may take care of a patient that has some degree of heart failure and be very comfortable with that. But periodically, as a general cardiologist, we will refer to Dr. Vullaganti, and sometimes it's just a one-time consult. It's sort of, you could just get an opinion am I really on the most optimal regimen that I need to keep me healthy long term? And then potentially you might follow up with your general cardiologist in the future. So there's many expertise out there that you basically could benefit from. So I think definitely asking about getting that right care, and knowing that there are people out there who may have yet another step above in terms of really getting you on the most optimal regimen. So yeah, we are lucky to have that expertise at Lenox with Dr. Vullaganti now. So this is a great overview. Really appreciate you joining us tonight. And any other messages for our audience? Anything you want them to take away from this talk?
Yeah, just heart failure does not equal failed hearts, and we have lots of options. Hopefully next time I talk, we'll have changed the name heart failure to something else, but right now that's what we're stuck with.
Good. We'll let you work on that in the interim. Thank you. So yes, thank you everyone for joining us for our Building Bridges to the Community lecture. And Dr. Vullaganti is our great doctor at Lenox Hill and taking consults, but definitely get checked out if you do have any degree of heart failure. Thank you again.
All right. Thank you very much for having me.
No problem. Take care.